Good afternoon and welcome to our UB Alumni Webinar Wednesday series. On behalf of the UB Alumni Association and the School of Management, we are delighted you are able to join us for today's presentation. My name is Christy Fields and I oversee the Alumni Career Services program here at UB. Today I am honored to introduce you to UB alumnus Larry Zielinski, Executive in Resident for Healthcare Administration at the UB School of Management. Larry has led successful market-dominant organizations in both healthcare and banking over the last 35 years. He has also served as the president of Buffalo General Hospital, the flagship center of the Kaleida Health System. Prior to that, Larry was the president of the Visiting Nursing Association of Western New York, developing that organization into the leading home health provider in the regional marketplace and one of the most prominent agencies in the country. Larry also currently runs his own healthcare consulting practice. As many of us are aware, few things are more controversial or complicated than healthcare reform. In today's webinar, Larry will share his insight on what may come next and how the repeal and replace effort may affect individuals, healthcare providers, businesses, and taxpayers. I am aware that some of you have already submitted some questions, and we will leave some time at the end of today's webinar for Q&A with Larry. If you have any questions during the webinar, please submit them through the chat question box on your screen. We will do our best to get to any questions, and Larry will leave his contact information at the end of the presentation for any questions we do not get to. With that said, it's my pleasure to turn it over to Larry Zielinski.
Well, thank you, Christy, and thanks to everyone on the line for joining us today. You know, my original premise for doing this was to talk about the impact of the Affordable Care Act's repeal, since the Republicans have had 7 years to figure out how to repeal it. But we all know what happened there, and now we're dealing with, I think, something worse almost, because we're dealing with a ton of uncertainty and we really don't know what's next. I guess we shouldn't be surprised, because the federal government's been dealing with healthcare reform over the last 70 years since the Truman administration, and it always is highly, highly politicized, and it's certainly more partisan than ever right now. And the problem with politicizing things is you are reduced to sound bites and phrases. And so here's a quick summary of the Republican view of the Affordable Care Act, also known as Obamacare. And here's the Democratic view of the current Republican repeal and replace effort. Okay, any questions? I will continue to move on. So the Kaiser Family Foundation, a nonpartisan think tank, has done polling on the Affordable Care Act since its inception in March of 2010. And you can see from this slide that as this repeal movement gained momentum, the Affordable Care Act suddenly became more popular, and it is now, the country is really very, very split on what's favorable, a favorable view or an unfavorable view of the Affordable Care Act. In that same poll, which they do monthly, by the way, they asked, what do you think President Trump should do? And you can see that even among Republicans and people who are big supporters of the president, the plurality now is to try to make the law better, try to, rather than let it fail and just repeal it, do what you can do to try to make it better. So that seems to be obviously with independents and Democrats, but also with Republicans, as you can see. So, just trying to step back here, it's complicated. You get into these details. What are we talking about? And, what have Democrats and Republicans been talking about over the last 70 years? Well, it's who is covered by health care? These three kind of major questions. Is health care a public good that all citizens should have access to, or should, we're a free market capitalist system? Is it a free market? What's covered? Does the government have responsibility to say that, when you buy health insurance, that should have certain, foundational elements, or should consumers be free to pick products they want and have the free market determine, which products are purchased and which aren't based on free market principles? And then who pays? It's expensive. Should it be something that is progressive, based on income? Free for the poor, like the Medicaid system, and then progressive based on incomes, or should it be more market-driven? And if you're on the Republican side, you're concerned about the entitlement budgets, which Medicaid and Medicare are two of the biggest components of federal entitlements, and should we start to control those? So just to kind of set the stage, I wanted to make sure everyone understands how people are covered by health insurance in this country. So this is the latest data I could get from the Census Bureau, 324 million people in the country. The majority of the country, or not the majority, but the plurality of the country are covered by employers, employer-based health insurance. That's a uniquely American institution. You won't see it anywhere else in the world to anywhere near this degree, but 48% of the population are covered by employers. And of that, the majority of that number are covered by self-insured employers, meaning the employer has taken on the risk for their employee base, and they use health insurance companies just to administer plans. So employers are the big health insurers in the country. Then you see the government programs, the Medicaid and the Child Health Insurance Program and the Medicare program combined. That insures about a third of the country. Of those numbers, there are about 9 million people that qualify for both Medicare and Medicaid. So Medicaid for the poor, Medicare for the elderly and disabled. And so that 9 million is double counted in those numbers. And then the group that is getting so much talk in this current debate, and that's what we call the non-group market, which is individuals and small business. It's 22 million people overall, and of course you've all heard about all the controversy over the Affordable Care Act health insurance exchanges, which we'll talk about some more. That covers 12.2 million people, which is about 4% of the total population, but it seems like it's the only thing people are talking about. We've got 95% of the talk on that 4% of the population, and we'll talk about why that is. And then the other number to focus on is that uninsured number at the bottom of the slide. Prior to the Affordable Care Act, that number was in the 45 to 50 million range. It's now down to 29 million. So the rate of uninsured is down to 9%. It is the lowest number that it's been in the history of health insurance in the United States. Okay, so what I wanted to talk about is these 7 features of the Affordable Care Act, and we're going to run through them one by one, and then talk about what the immediate future will hold. So the first 5 of them are really focused on expanding coverage. So how do we get that number from 17% uninsured down to 9%? Well, it was through a combination of these 5 items. So I'll go through, and this is the major focus of the Affordable Care Act, was to expand coverage to as many people as possible. Didn't do it entirely. We still have 29 million people uninsured, but it's a big improvement. And then what everybody is so concerned about is the cost of health care, right? And really the Affordable Care Act, there is an important provision in the Affordable Care Act that I'm going to talk about, number 6 on this slide. But it was not, it's a longer term effort, and it has not had much of an impact at all on costs, which I think has lended to how controversial the act is, because costs have continued pretty much unabated. But those first 5 items dealing now with expanding coverage, the 6th item with controlling cost on a longer term basis, and then the 7th item, how are we going to pay for the program? So we'll go through these one by one. So the first is expanding coverage, and one of the ways to do that is to make sure that we have basic consumer protections in all health insurance that's sold. So I'm sure you've heard about these elements, the covering of young people up to age 26 on their parents' plans, and an important coverage of pre-existing conditions. So if you have a pre-existing condition before this act was passed, insurers had the ability to basically exclude coverage or drop coverage. Neither of those are allowed now. I don't think both items are going to be, I think are kind of hardwired into our landscape right now. All of the Republican reform proposals keep those 2 elements. There is some talk now in appeal to some of the more conservative members of the Republican Congress to maybe tinker with that pre-existing condition feature, but I think both of those things are going to stay in however this turns out. The essential health benefits, the 3rd aspect of expanding coverage, is a little more complicated, and I wanted to go into it because it's really gotten a lot of attention lately. So these essential health benefits are 10 kind of foundational coverage elements that the Affordable Care Act said had to be included in all of the individual market and small group market exchanges, though the plans that were sold on the health insurance exchanges. It's not required actually in large group employer plans, the 158 million people. So the majority of people don't have this protection. But when you see the 10 elements, you'll note that your plan is at where you work has them, because most employer plans already have these elements already. But this was important right from the very beginning. You'll all remember kind of the biggest public relations fiasco of the Obama administration's marketing of this plan was President Obama and others in his administration saying, if you like your health plan, you can keep it. Well, if your health plan didn't have these required 10 elements, you couldn't keep it. And that did affect about 4.7 million people who had health plans on the individual market that did not have these required elements. And so the insurance companies, according to the law, had to stop offering them. And boy, that has been pounded and pounded and pounded by opponents of the law over time. So here are the 10 health benefits, and you'll look at them and they seem, pretty reasonable to most people. Ambulatory coverage, meaning, non-hospital related coverage, prescription drugs, emergency care, obviously hospitalization. And so, to most reasonable people, these essential benefits are, pretty foundational. And as I said, they're in the large group markets. And so these are now mandated to be in those small group and individual markets as well. Okay, so what is going to happen? What's the positions of the major parties now? Well, this was a major talking point for the Republicans, because they said these mandated benefits are one of the reasons why premiums are so high, that if you require insurers to put things basically in plans that people don't want, that will drive up costs. And if we eliminate benefits that some people may not be interested in, like if you're a single male, you're not going to be interested in maternity coverage, that could reduce costs, and it may result in more innovation from health insurance companies. There was a big split on this issue. The Republican Party, as most of you probably know, is very split right now between very conservative elements, the Freedom Caucus, and more moderate elements, and they were very split on this. The Democratic position was, we need this kind of protection for people, that the removal of these mandated benefits is going to result in products that are going to have less coverage and maybe cheaper in premiums, but is going to result in more financial crises as people actually get sick and need to access their health care, use their health care, and find that something's not covered. The term is it's going to be a race to the bottom. So that's where these two things stand. I think as we continue to wrestle with what's next in Washington, this will be a key element of the debate. Okay, the second item of my 7, and another one to expand coverage, is the individual mandate. And the rationale here, very controversial right from the beginning, was we need to create a health insurance risk pool like every other insurance risk pool. And just the concept, which is, I think pretty well understood, is the concept of insurance is we're going to have a lot of people buy an insurance product, and most of those people, the vast majority of people, are not going to need the insurance, but they're going to pay premiums, and that's going to cover the cost of the people that actually do need insurance. And so that was the focus of the individual mandate. All citizens in the country have to be covered and have to purchase insurance. If you don't have coverage, there's a tax penalty, and the tax penalty, a lot of people think, was set too low. It's a maximum of $2,085 or 2.5% of income, and if you compare that to the cost of a health insurance plan, the fear is, and I think it's a legitimate fear, well, people are going to look and say, I'll rather pay the penalty than buy health insurance if you're healthy. So that's the individual mandate. Very consistent Republican position that the government should not force people to purchase something they don't want. And the Democrats obviously think that the individual mandate is foundational, that it establishes that solid risk pool. If we remove the individual mandate, we'll have fewer of those healthy people that are paying into the system. The resultant pool will be older and sicker, and that will cause premium costs and out-of-pocket costs to go up even more. Moving on now to number 3, this is a huge issue. This is the Medicaid expansion. So in the United States, the Medicaid system, this is the system to insure the poor, is administered by each of the 50 states individually. It's paid for in a combination of federal and state dollars, but it is administered by the 50 states in Washington, D.C. So we actually have 51 different Medicaid programs across the country, and they all have different eligibility limits, meaning the eligibility limits are determined by where a person's income stands relative to the federal poverty level. And some states have very high, some states like New York and California have very generous Medicaid plans. Other states, particularly in the South, have very restrictive Medicaid eligibility plans. The Affordable Care Act said, listen, we want to standardize this across all 50 states and the District of Columbia by saying that you're eligible for Medicaid if you have an income level up to 138% of the federal poverty level. And, by the way, we know states are in trouble in terms of their state budgets, so we will pay. We're not going to, most of the Medicaid dollars are split between federal and state funding. We're going to pay for the vast majority of these expansion Medicaid recipients according to the schedule that's on the slide. Now this was, there's been a series of court challenges to the Affordable Care Act. The most famous one was right after it was passed in 2012, where the Supreme Court upheld the constitutionality of the Affordable Care Act in its entirety, except for this feature. They said this feature was an abrogation of states' rights, and states would not have to be compelled to comply with this increase in eligibility limits. And so here's just to tell you what the federal poverty limits are. So, this is saying that the original intent of the law is that if you were an individual making $16,394 in 2017, you'd be eligible for Medicaid. And then again, the Supreme Court overturned that and said, no, we're going to make this state up to the state's discretion. So here's just an idea of, here are Medicaid income limits for parents with dependent children. And you can see the dark blue states are all over that 138% limit, but there's a big swath of the country, predominantly in the South and the Midwest, and the upper Midwest, that are below that income level. And so a state like Texas, for example, very populated state, has only, you have to be making 18% of that federal poverty level, or a couple of $1,000s basically, if you have a dependent child and qualify for Medicaid. So obviously not a lot of people are qualifying for Medicaid in these states with very, very low eligibility limits. Now, here is a map that says, okay, since the Medicaid expansion is now voluntary, which states chose to take advantage of it. And the orange states on this map did not adopt. So we have 31 states in the District of Columbia that adopted the Medicaid expansion, and 19 states that did not. And if you look at these two maps, you'll see that they are very similar. So the states that had low eligibility limits to begin with, largely Republican states, said, we're not having anything to do with this. And the states that were predominantly, Democratic-leaning states, there are some exceptions, said we will take the expansion. The exceptions are states, though, like Indiana, where Vice President Pence is from, a Republican state that expanded, West Virginia, a very Republican state that expanded, Montana expanded, Louisiana expanded. So there are some exceptions. But by and large, the Republican states sat out, the Democratic states leaned in. So what is the impact? What's the discussion now in Washington? Well, the Republicans' position is, forget about this expansion. Medicaid's too expensive to begin with. We need to put Medicaid on a budget. Medicaid has been funded the same way since it was initiated in 1965 with this federal-state split. And we need to put Medicaid on a budget. So we're going to issue either block grants or per capita spending limits for all of the Medicaid recipients and say, states, here's your block of money to cover your Medicaid recipients. You figure it out. So it repealed the expansion and do a fundamental change to Medicaid funding. And that is, again, getting at this big Republican sticking point on the growth of entitlement programs. The three big entitlement programs, Medicaid, Medicare, and Social Security. This is addressing, obviously, just Medicaid. The Democratic position is, wait a second. This was the largest impact of the Affordable Care Act. 12.5 million people additional were insured under the Medicaid expansion. And that states, if they lose this Medicaid expansion subsidy, are going to be faced with a tremendous burden, and they're already stretched. So we have to keep it. And it's substantial, obviously, in states that were below the Medicaid eligibility levels and went back up to that 138 level. But it's also substantial in states like New York, because one of the things that states like New York did, or California, that were already at the 138% level for Medicaid eligibility, is that they found additional Medicaid recipients, probably because of the way it was marketed and better familiarity of the rules, more aggressive marketing. And New York's Medicaid enrollment actually grew by 700,000 during this time period. So it'll have an impact across the country if this Medicaid expansion is repealed. Okay, moving on to number 4, and another way to expand coverage. We talked about expanding Medicaid, and now we're talking about, okay, we want to make so many employers already have employer-based health coverage, but we want to make it mandatory. So they made an employer mandate that you had to offer health insurance if you had full-time employees of 50 or more, okay? And they redefined, this is very controversial, they redefined the nature of full-time to 30 hours per week, not the 36 and a half or 38 or 40 that we're used to. And then there was this, if you did not offer health insurance, there were penalties. I won't get into the penalties, that's getting a little into the weeds, but if you did not offer health insurance, if you had 50 or more full-timers and you did not offer health insurance, there were a penalty. The thinking at the time, again, was these penalties are less than actually the coverage cost of offering health insurance. So their thinking early on was that maybe we would see some drop-off of employers into the health insurance market, and they would just take the penalty. But as it turns out, I think it's been largely symbolic. There were 200,000 businesses across the country impacted by the employer mandate. 94% of them already offered health insurance, and as you can see from the next slide, it didn't change much. So, going back to 2010, you can see the top line there is larger firms of 100 and more. That's still in the high 90s, 97, 96% of firms offering health insurance. The middle-sized firms between 50 and 99 have dropped off a little bit. There's been some drop-off there, but not really substantial. And then, the big drop-off has been down at the bottom in small firms that weren't even part of the employer mandate because they had less than 50 employees. So I think that trend is just employers saying healthcare is just too expensive, regardless of the Affordable Care Act. Over time, you can see that small employer group has been steadily dropping off. Whoops. Okay, I want to talk really quickly about another employer-related issue, and that is the Cadillac tax, which is an excise tax on high-cost plans. Over time, employers have incented executives with very rich benefit plans, health insurance plans, and on the other end of the spectrum, unions have negotiated, very attractive benefit plans. And the theory here is these high-cost plans encourage unnecessary utilization. If you have a plan that covers everything, you're liable to be a bigger user of unneeded services. And so it said, we're going to start to penalize these. If the value of the plan that your company bought for you is over these numbers for an individual or a family, there's going to be a very substantial tax, a 40% tax over those amounts beginning in 2018. Hugely unpopular, lots of pushback, It has been pushed out now to 2020, and with the state of affairs the way they are, I don't think this is ever going to happen. But this is a big issue with employers, is this Cadillac tax. So what's going to happen if the employer mandate goes away? You may continue to see some small employers drop out of the market, but I think it'll have very little impact on large employers. They're going to be happy about the drop in administrative costs and the elimination of the notion of this Cadillac tax. But other than that, I don't think you'll see much of an impact at all on large employers. Then there's the question of what will happen to part-time hours. Critics of the Affordable Care Act said it's going to be a job killer because of this 30-hour rule that said if you have a full-time employer, if a 30-hour employee is now full-time. But if you look at the numbers on the slide below, that really didn't happen. We did have some minor increase in part-time workers between 25 and 29 hours, but the 31 and 34-hour employees dropped slightly, but not really substantially. So in a nutshell, I don't think the employer mandate had much of an impact at all, and I don't think it's going to have much of an impact if it's repealed. Okay, number 5, and this is the big issue. This is the favorite target of opponents of the Affordable Care Act, is this non-group coverage. So we covered Medicaid expansion. We're going to ask all individuals must purchase health insurance. We're going to ask all employers to provide health insurance. And now what about people who are individuals or work for small businesses that don't provide health insurance? They go to these individual markets. And this is where the state health exchanges came into play. It has been, I have this phrase, it's 4% of the total insurance market, but it's been 95%, in my opinion, of the discussion. So again, this is like a Google for health insurance, where you can go on an exchange, compare plans, and purchase a plan for individuals or small businesses up to 100 employees. The law said we're going to make this simple. We're going to have 4 different choices, actually 5 different choices. A bronze plan that has an actuarial value of 60% of cost, meaning that if you incur $1 worth of health cost, the plan will pay 60% and the person will pay 40%. A silver plan, 70-30, et cetera. A gold plan, 80-20, and a platinum plan, 90-10. Obviously, the platinum plan is going to be the most expensive, the highest premium. The bronze plan will have the lowest premium. There was also a feature to try to attract young people by adding a catastrophic plan up to age 30 to, again, try to get those young, healthy people into the market to increase the risk pool. These plans were subsidized, meaning that if the premium was too high, there was a subsidy to help pay the premium. If the cost-sharing side, the deductibles and out-of-pocket costs, co-pays were too high, there were cost-sharing subsidies. It's a complicated formula, but the gist of it is it heavily subsidized poorer people and less, but there was a sliding scale up to 400% of the federal poverty level. Again, go back to that earlier slide. It basically was something that covered most of the people in the individual marketplace. This is a little bit dated, but I think all the numbers I've seen are similar to this. So 87% at this point in time of the people who selected a marketplace plan got a premium subsidy. Only 13% of the people on the federal exchanges selected a marketplace plan without premium subsidies. So, all we've heard about is how unstable these markets are and how premiums have just jumped through the roof. And it has a problem, but it only affects a tiny minority of the people who actually purchased plans, because the others are receiving these federal subsidies. These plans are pretty inexpensive. So this is a chart that compares, per capita cost, health insurance spending for a typical Medicare enrollee, a Medicaid enrollee, a typical employer-sponsored enrollee, and then the marketplace. And you can see these marketplace plans back in 2014 were relatively low-cost plans compared to everything else. But of course, we've all heard about the premium jumps? Why have the premiums been jumping? And this is just a chart that shows across all, markets all over the country, there was a variety of experiences with premium jumps. You can see markets like Phoenix, which, the president and ACA opponents are very quick to jump on, where we had a 145% increase in premiums from 2016 to 2017. Other markets was more stable. Indianapolis actually saw premiums drop. Boston saw premiums drop. Across the country, there was a 22% increase in premiums on the exchanges. Again, this is these 12.2 million people across the country on the exchanges. And so the question is, why are these markets so unstable? And this is, all of the talk about the Affordable Care Act seems to have focused on this one issue, which I think is really overblown. But anyway, here's why they're unstable. When you go back to the concept of insurance markets, the more people you have in an insurance market, the more stable a market's going to be. So when you have tiny markets, 12.2 million people split among 50 states across the country, and then interregional markets, the Buffalo market, the Rochester market, the Syracuse market, the Utica market, the Albany market, the New York City market, you're going to have very tiny risk pools. And if you have, you can do your best to estimate what your costs are going to be, but if you have just miss by a little bit in terms of high cost people, or you don't sign up enough low cost people, premiums are going to jump. And despite a lot of efforts, I think those young invincibles, the young people that, despite the individual mandate and all of the incentives, they did not sign up in sufficient numbers. The other thing was, as you saw by the previous slide, premiums were quite low to begin with. I think that was a way for them to for health insurance companies to establish market share in these markets. And now they're catching up. And then an untold reason is this last item, and it's a little complicated, so I'm going to really summarize it. But anyway, the federal government knew this was going to happen, and so they put in place, as part of the Affordable Care Act, risk mitigating tools that basically said to health insurers, if this happens, if your risk pool turns out to be much higher than you anticipated, we're going to protect you. And there was a couple of different ways they did that. And the major programs that did that expired at the end of 2016. And certainly with the state of affairs in Washington, they were not going to be renewed by a Republican Congress. And so those risk mitigating factors were pulled out from the individual markets and premiums exploded. So those are the reasons why they are so unstable. These can all be fixed. There are all ways to make these markets more stable, and the question is, will the new administration do that? But we've heard, and if you look on the right side of this slide, 21% of the markets only have one insurer in them, 22% only have two insurers. So you've got a big chunk of the market where the markets are so unstable, insurers can't get a handle on costs. They've said, we're not going to play. And that has been magnified now with all of this uncertainty. We're seeing insurers drop out of these markets on a routine basis as the government continues to kind of fiddle around and not come to any conclusion. So what's going to happen if it's repealed? I'm not sure what the Republicans' position is on exchanges, but we know when you hear the president talk about Obamacare is going to implode or explode, or I'm not sure what the difference is. This is what he's talking about. He's talking about the individual markets and this premium, this premium instability. And so what the GOP wants to do, what the Republicans wanted to do, was to eliminate those subsidies that I talked about, to eliminate the mandated essential benefits, which I've talked about. Other things they think will reduce premiums is to open up insurance sales across state lines, and also to create, kind of isolate the high risk people into a separate pool that would still have to be funded. So that is the position that they promoted in their repeal effort. And the Democratic position was, these 12.2 million people are in jeopardy of losing their insurance, especially if the subsidies are pulled away, since so many of them, 85% or higher, are getting subsidies. If those subsidies are pulled away, they will pull away. And the only thing we'll be left with are really sick people that must purchase insurance. Will have a very, very difficult, it'll make the situation worse, basically. Okay, I wanted to spend some time on this. So this is the item 6 on my list of 7, and that is how are we going to get at cost? All the first 5 things I talked about were, again, expanding coverage. This is the part of the act that is probably least well known, but it was the attempt long-term to solve the cost problem. And just 2 quick slides. You know, spending's upward march. Per capita spending in healthcare has gone up, up, up. You can see the numbers. It's projected to go up to over $15,000 per capita by 2025. And look at the share of gross domestic product. So we're now spending 18% of every dollar in America on healthcare, and that's projected to grow. Almost everyone thinks that's unsustainable. But even more kind of concerning is the slide on the right, which compares us to other developed countries. So it compares health spending and life expectancy. So we're spending a lot, but look at our life expectancies, which is kind of the ultimate outcome measure. And compared to European countries, Japan, Australia, our life expectancies are lower, our costs are much higher, more than double the average for these developed countries, as you can see from this slide. So something's got to change. And in my opinion, the thing that has to change, I don't want to be overly simplistic, but it is fee-for-service reimbursement. The way that we pay for healthcare in this country is if you do more, you get paid more. And the underlying foundation of the reimbursement system is cost-based. So if you do really expensive things, you're going to get paid a lot. Like if you do surgeries or complex hospital care, you'll get paid a lot for that. If you do lower cost services like preventing people from getting sick in the first place, you get paid very little for that. And so, you know, Tom Northrup, the leadership guru, says all organizations are perfectly designed to get the results they're now getting. If we want different results, we have to change the way we do things. This has to change. And so in the Affordable Care Act, they created something called the Innovation Center. And this has prompted this movement towards value-based care. And what value-based care is a move away from fee-for-service and a move towards saying, look, we're going to combine, we're going to try to align the financial incentives with quality incentives. We're going to pay for health care, but only if we get the quality that we're looking for. And it obviously, the Innovation Center was designed to basically try to experiment across the country with different ways to pay for health care differently. And so this is a complicated slide, but basically the idea is move the healthcare system up to the top right part of this spectrum, to the point where we're saying we want the providers, the people that are actually providing care, doctors, hospitals, health systems, to bear the risk of the cost of this, the health insurance cost of a population, the health cost of a population, and to benefit from them if they're delivering really high quality. And so I wanted to just focus on a couple of these examples. And the first is something called an accountable care organization. So what an accountable care organization is it's a network of providers, doctors, hospitals, other providers that are responsible for a population of recipients, in this case Medicare recipients, but it could be others. And they're basically put on a budget. And they're saying, if you manage the care of this population on this budget, there's a bunch of different formulas, but the revenue now is fixed. And if you come in under budget, depending upon the formula, you may be able to share in those savings, or again, depending upon the amount of risk that you're assuming, take all of the savings, but you have to coordinate care, you have to provide high quality, or else the system doesn't work. And so these ACOs, as they're known, have taken off across the country. This is where all the Medicare ACOs are. There's almost 500 dealing with Medicare patients, but even more impressive, the commercial insurers have also jumped onto this model, and now we have over 800 ACOs in total, Medicare, Medicaid, and commercials, covering 9% of the country. Now, that's not enough, but the thinking is, if we can get more people covered under this type of reimbursement, we could start to get a handle on health insurance costs. They have had mixed financial results. It's an early model, but I think it holds a lot of promise. The other one I wanted to talk about that you may have heard of are bundled payments. So bundled payments, where ACOs that I just talked about are dealing with a population of people. Bundled payments is back on the individual level. And what it says is, listen, we're not going to pay individual providers for everything they do on an individual case. Let's take a knee example, a knee replacement, for example. You have testing done before your knee replacement. All of that is charged to Medicare in this case. You go see your doctor for a pre-surgical exam, that's charged to Medicaid. You go into the hospital charges you for Medicaid. The surgeon charges Medicaid. The anesthesiologist charges Medicaid. The hospital stay, you charge Medicaid for that. The drugs that you're on, that's a charge to Medicare. After your hospital stay, you go into a rehab center, that's a charge, or have home rehab. We're going to stop doing that. We're going to say all aspects of this patient's care over the entire episode, from the preoperative stage right through rehab, we're going to pay in a bundle. So that's the concept of bundled payments. There are many bundles, over 2,000 bundled projects across the country. And again, there's a couple of mandatory ones that are being have just been initiated. The one on joint replacements I just talked about, also one for some oncology patients. And so what's going to happen if we step away from this value-based care initiative? And the head of Health and Human Services, Tom Price, is very much, I think, in favor of moving away from this because he thinks that it impacts patient choice. I don't think it's going to stop the movement, but I think it'll certainly slow it down. I have this funny quote. You may think it's funny. Maybe it's gallows humor from a health system CFO. We're going to ride the fee-for-service horse until it dies because, again, the value-based payment movement is putting more risk on providers, where a lot of people think it should be, to manage costs and manage care. So that's item number 6. And then finally, I wanted to talk about the way the Affordable Care Act was funded and what's going to happen with that. One of the things that I think Democrats probably should say more is, you may not like this, but we paid for it. It is fully paid for. The cost estimate by the Congressional Budget Office was $938 billion over 10 years originally. That's jumped up, like a lot of these costs do, up to a mere $1.25 trillion. It was all funded by new taxes and fees and savings from the Medicare and Medicaid program, but the CBO estimate was it will actually reduce the federal deficit. So these are all of the items that are involved: reduced Medicare Advantage payments, reduced payments to hospitals, higher taxes basically on high-wage earners, a series of taxes on participants in the healthcare system, pharmaceutical companies, health plans, medical device companies. A lot of these, you'll notice, have been put on hold by the Republican Congress over the course of the last couple of years. So what's the impact of a repeal of the funding? Well, the Republican position is it's $1 trillion in taxes, fees, and cuts, and it's crippling the healthcare system. And the Democratic position is, yeah, well, we're fully paid for, and eliminating these funding sources is going to really undercut the foundation of the program. It'll cut off the source of the health exchange subsidies. It'll cut off the source of the Medicaid expansions, and it's highly unlikely that states would step up to subsidize the subsidies that the federal government took away, and we'd have a lot more uninsured people. So let me just recap. This was the slide I showed right in the beginning, the different insurance markets, the employer market, the Medicaid market, the Medicare market, et cetera. And this is the impact on each of these markets. So the biggest market, the employer market, I would argue there's been very little impact on, the 48% of the country that gets their insurance from the employer market. The vast majority already met minimum coverage capabilities. They already offered health insurance. There was a lot of concern about the Cadillac tax, and the regulations that employers had to comply with. But basically, I don't think the Affordable Care Act had much of an impact on the employer market. Medicaid, huge impact, obviously. 12.5 million additional insured. Most of that in the 31 states in the District of Columbia that expanded Medicaid. Not as much, obviously, in the 19 states that did not expand Medicaid. I haven't talked a lot about Medicare, but the taxes on high wage earners, the decreased payments to insurance companies and hospitals for Medicare patients, increased the solvency of the Medicare Trust Fund by 11 years. So we don't hear a lot about that, but you probably heard the Medicare Trust Fund is going broke. Well, it's still going broke, but the going broke has been pushed off to 2028. And again, I would argue the largest impact is the long-term effect of these efforts of the Innovation Center and this whole value-based care movement. If that is disassembled, what is going to happen? And we're going to rely on the private market and state Medicaid systems to kind of advance the change in payment that I think is so critical to getting our hands around healthcare costs. Huge impact in the non-group market. These are again the health insurance exchanges that we talk so much about. 12.2 million newly insured. The vast majority of those qualified for subsidies, and we talked about how unstable the market is in many parts of the country, but it's mostly in rural, lightly populated areas where we have the most uncertainty. And then on the uninsured side, we've reduced, as I said before, to our lowest levels of uninsured in history, down to 9% of the population. It was as high as 17% back when the act was passed. So what is the new administration going to do? That's the big question, and I've got 4 options here. This one I think is definitely going to happen. We're going to start to see Tom Price, who is a very conservative Republican who now is in charge. He's a physician. He's now in charge of Health and Human Services, which is the regulatory body that controls the Medicare and Medicaid systems. They're going to start, I believe, to begin regulatory measures to perhaps undercut the impact of the Affordable Care Act. They can do this without any help from Congress. How can they do this? They can do this by saying to the IRS, for example, don't enforce the individual mandate. And they can do things by not supporting the health insurance exchanges the way and have those problems that we just talked about continue to exacerbate. And that is how we're going to see this explosion and implosion of those markets that the president talked about. Second option, there could be another Republican-led repeal, and that could either be one of 2 ways. A conservative appeal to the Freedom Caucus, which is these hard right conservatives, by really taking away being more aggressive on the subsidies, the Medicaid expansion, the block grant funding, and try to form a coalition on the right side of the Republican Party. I personally don't think that's feasible. Or maybe even more unlikely, they could attempt a bipartisan attempt to try to appeal to Republican moderates and Democratic moderates to try to establish a coalition there to kind of fix the Affordable Care Act. That would be my hope. I think it's highly unlikely in this politically charged environment. I think what's most likely is item number 4, which is more stagnation. But we'll see what happens. And with that, Christy, I am done. These are great public resources. If you're a nerd like me and you love this stuff, the Kaiser Family Foundation, the Commonwealth Fund are 2 excellent free sources of information. There's my email. I'm really good on email, not so good on phone calls, so I left my email address if you have any questions that we don't get to now. And Christy, I think we have about, 11 minutes for questions.
Excellent. Thank you so much, Larry. Just a couple of things that I wanted to mention, a couple of questions that have come in. Can you touch a little bit on, Larry, how does palliative and end-of-care life come into play with ACO?
Okay, palliative care, okay, so an ACO, with ACA or ACO, Christy?
It came in as ACO, but I wasn't sure if it was meant to say ACA.
Yeah, well, you know, we love acronyms in healthcare. The ACA, so I'll try to answer it both ways. How about that?
Perfect.
The ACO is those accountable care organizations. So what those are, again, are a network of providers. We have one here in Western New York for the Western New York listeners with the Catholic Medical Partners. So it's a network of all the Catholic hospitals and 1,000 doctors in the area. And they are responsible for the health of a population of, I think it's about 40,000 Medicare recipients. They're on a budget. If they make their budget, they profit. If they don't make their budget, they don't profit. That's very simplistically. So in terms of palliative care, again, is symptom control. It's end-of-life care when you've got a terminal patient and the family and the physician have decided that this is an incurable state. We're going to really focus more on comfort measures and symptom control. In an organization like an accountable care organization, I think you would see an increase in that level of care, because I think what the good ones are doing is they're going out to people. This is a complicated subject, but they're going out to people before a crisis hits and say, what do you want to happen if this happens to you? And let's document that. So, you know, I'm a relatively healthy blank-year-old. I won't give my age away. But if I'm in a situation, hopefully not too soon, where I'm in this level where I need, extraordinary measures to keep me alive, or maybe I would prefer to take just comfort measures, I make that decision now. I write it down. I give it to my doctor. And then when the crisis hits, people know what happens. These are called advance directives. And so I think in an ACO environment, you would see more of a push on advance directives so that we do less needless, very expensive end-of-life care. You know, we're talking about heroic measures that are not going to have any impact. And in some cases, a lot of doctors will tell you, has a negative impact on the quality of life of patients.
Excellent. Thank you, Larry. Another question to think about, would it be a good thing for the regional markets to go away and pools of insured to be anywhere so the regional insurers merge and have bigger pools and find cost savings?
Yeah, you know, that sounds like a really good idea on its surface, because you're increasing the risk pool. I think that's the focus of the question. You've seen a lot of this happening already. There has been a lot of consolidation in the health insurance market. You've read about some big mergers happening, especially on the for-profit side. And so this is happening already. Insurers are already expanding. It's not happening quite as much in our state, in New York, because we're basically a nonprofit insurance market. Here's the problem, and this is also the problem with selling policies across state lines. It's one thing to say we're going to expand our risk pool by the way the questioner asks, and it's another thing to actually do it, because in order to do it, you have to expand your provider pool. So in other words, let's suppose that United Healthcare, which is entering, by the way, our Western New York market, they're the largest for-profit insurer across the country, wanted to come into this market, and they have this huge, risk pool that they already have. They've got to go out and develop a provider network, hospitals, physicians that will accept their payments. So let's say they come in and they go, boy, we're going to enter the Western New York market. We think, this isn't true, by the way, our insurance costs are quite low. We think we can come in with an even lower price policy, and we're going to enter this market. Well, you've got to go out and convince hospital systems and doctors to take less reimbursement to accept your policy. So the point is, I think it's the question is the answer is it's happening on a scale in various parts of the country, but it's not as easy as it sounds because you have to have those existing provider networks.
Wonderful. Another question too, and I know some of us may have been hearing this in the news a little bit, would you say that the ACA is very comparable to the Canadian system?
No. The Canadian system is a government-run universal healthcare system. It's actually administered by the provinces, but if you're Canadian and you're a Canadian citizen, you have healthcare. A lot of left-leaning people, the Bernie Sanders followers. This is obviously a big emphasis of Bernie. Was we need universal healthcare. I would say most countries, developed countries around the world have some form of universal health care. This is not universal health care. The original intent of the Obama administration was to try to have a universal health care through a mix of a private-public mix. And that's really what the ACA is. So what's the public part? We've got Medicare for old people, we're going to expand Medicaid for poor people, and then we're going to have these different mandates that are going to cover people in between. There was originally an effort to have people may have heard of the public option. So in addition to all the things we talked about in this webinar, they wanted to have, if the private insurers won't go into one of these markets and insure people, we'll have a public option for people to choose from or to compete with. And that was eliminated from the original act. And so the answer to the question is the long answer. It's not like universal health care. I would say it's a long way from universal health care like the Canadian system.
All right, great. We'll do one more question, Larry, and then any additional questions, I'll be sure to get answers from you to forward on to the group. But the last question for today, is it feasible to reduce the high cost of prescription drugs by limiting the charges for drugs to the charges in other countries for the same drugs, or by allowing interstate purchase of drugs or other ways of increasing competition for drugs?
Oh boy, we need another webinar for drugs. I think that there is pretty, I guess I shouldn't say universal. I think there's a lot of people that think that we should allow our government programs to negotiate drug prices. So the largest purchaser of drugs in the country is the federal government through the Medicare and Medicaid programs. And heretofore, for a variety of political reasons, they have been unable to directly negotiate with drug companies over the price of drugs. So picture yourself in any other market, you're the largest buyer of a particular product, and you can't negotiate the price. That's what we have. And so that to me is one thing that might have drive the cost of drugs down. But you know what? The United States is for good or for bad, is the pharmaceutical development engine of the world. Okay? I just taught a case, I teach obviously, and I just taught a case the other day on the hepatitis C drug that people may have heard of. So we now have a drug that basically can cure hepatitis C, which is a terrible disease. It is a worldwide disease. In the United States, it cost upwards of like $14 billion to develop this drug. And in the United States, they are charging $84,000 for a 90-day supply. Now, if you do the math and the number of people that would, they're trying to make up that huge investment that they put into developing this drug. They're also marketing it across the world at a fraction of that cost to poor countries like Egypt and India. And so what we have is really an ethical debate is the United States going to continue to subsidize drug development for the rest of the world?
Wonderful. Thank you so much, Larry. I really do appreciate you taking the time today for sharing your knowledge and expertise with all of us on the line. We have recorded this presentation, and we will send it to you all within the next 24 hours. And just on behalf of the UB Alumni Association and the UB School of Management, again, a big thank you to Larry. We do want you to save the date for next Wednesday, April 26th, as UB alumna and Wegmans nutritionist Mallory Whipple will discuss added sugars, including why you should be concerned with too much in your diet, the difference between naturally occurring and added sugars, and identifying added sugars on nutrition labels. So in this webinar, you will come away with tips and advice to reduce added sugars as we celebrate National Public Health Month. We will share additional details in the registration link in our follow-up communication. In addition, we do have some upcoming webinars in the months of May and June on the following topics: sustainability and the supply chain. The UB libraries will be doing an archives showcase. We're going to talk about generations in the workplace. We're going to touch on venture debt, as well as due diligence for business, plus some Google Ninja tricks as well. So we hope that you are able to join us on a future presentation over the coming months. Again, on behalf of UB Alumni Association and the School of Management, thank you for joining us today. Thank you, Larry, and enjoy the rest of your day.